Welcome to The Explainer. Today, we're diving into a life-or-death question that doctors face every single day in the ICU. When is it safe to take a patient off a breathing machine? And we're going to see how AI is starting to provide answers with, frankly, astonishing precision.
So, when is it safe? For doctors in the intensive care unit, this isn't some philosophical question. It's a real, high-stakes decision they have to make every day, with a person's life literally hanging in the balance.
And get this, we're not talking about a rare event. Our source material points out that a staggering 40% of all patients admitted to the ICU need what's called mechanical ventilation. That's a form of life support that breathes for them when they just can't do it on their own.
And this brings us right to the heart of the matter, something clinicians call the weaning dilemma. It's a perfect name for it, because it really is a true medical tightrope walk.
You see, a mechanical ventilator is a bit of a double-edged sword. On one hand, it's absolutely essential for survival, but the goal is always to wean the patient off of it, to set them free from the machine. But if you get the timing wrong, either too early or too late, the consequences can be incredibly severe.
See, if a patient stays hooked up to that ventilator for too long, the risks just start stacking up. They can develop pneumonia, they can injure their vocal cords, their own breathing muscles can literally waste away. Every extra day on that machine just increases the risk of serious complications and even death.
Okay, so you're probably thinking, just take them off sooner, right? Well, this is the other side of that dilemma. Because as our source material highlights, about 25 to 30% of patients actually fail the weaning process. That means the breathing tube has to go right back in, a risky procedure that sends them right back to square one.
So you have this intense high-wire act. Don't wean too late, but don't wean too early. So how have doctors traditionally navigated this? Well, let's take a look at the standard playbook. For decades, it's been this very careful step-by-step process. Doctors wait for the patient's underlying illness to get better, they check off a whole list of clinical criteria, and then, if everything's looking good, they let the patient try breathing on their own. It's called a spontaneous breathing trial, or SBT.
But here's the problem, and our source material makes this really clear. These traditional metrics, as useful as they are, just aren't reliable enough on their own. They give you a good general idea, sure, but they can't accurately predict the outcome for one specific person.
I mean, to put it into perspective, even the so-called gold standard test, that spontaneous breathing trial, fails in up to 40% of patients the first time they try it. That is a huge amount of uncertainty when the stakes are this high.
And it's exactly this uncertainty that has basically rolled out the red carpet for a powerful new ally in the ICU: artificial intelligence.
You know, the best way to think about AI here is to imagine a kind of super consultant, a tool that can instantly analyze data from literally millions of previous patients, and it can see these complex patterns between hundreds of different factors that no human brain could possibly process at once, all to give the doctor a precise, data-driven recommendation. It does this using a kind of AI called machine learning, and the concept is actually pretty straightforward. You just feed the algorithm a massive data set of past ICU cases, all the successes and all the failures, and it literally teaches itself to recognize these super subtle patterns that predict who is ready and who isn't.
And what the AI sees, well, it's everything. It's not just looking at one or two simple numbers. It's weaving together hundreds of data points at the same time. The patient's age, their medical history, their lab results, their vital signs, and dozens of really complex, real-time parameters streaming right from the ventilator itself.
Okay, so that's the theory. Sounds pretty amazing on paper, right? But how well does it actually work in the real world? Well, the results from recent studies are, to be honest, kind of mind-blowing.
Get this, one model, which uses a technique that's really good at sorting data into two groups, like ready or not ready, was able to predict the chance of extubation failure with 98.3% accuracy. I mean, that is a level of precision that is just completely unheard of with the old methods.
And it's not a one-off. Another model using a different approach predicted successful extubation with 97.6% accuracy. And the really cool part? It did this using just 6 key pieces of information from the ventilator, which means it could be used easily right there at the patient's bedside. And look, these are not just theoretical predictions. In studies where they actually put these AI systems to work, the benefits for patients were real and they were significant. We're talking about an average of 21 fewer hours on the ventilator, shorter ICU stays, and fewer people having to be reintubated. So the potential here is obviously enormous, but And you know there's always a but with powerful new tech. This isn't some magic bullet. There are some very real challenges and some tough questions we need to figure out. You really have to see it as a balancing act. For all the promise of personalized predictions and better outcomes, there's the peril of what's called the black box problem. That's where the AI gives you an answer, but we can't fully understand how it got there.
And this raises some really difficult practical questions, like how is all this sensitive patient data being used and protected? How can you expect doctors to trust a black box they can't see inside of? And who's accountable if the AI gets it wrong? These are the real-world hurdles the medical community is grappling with right now.
So for now, the consensus from our source material is crystal clear. AI is meant to be a powerful supportive tool. It's an expert consultant, but it is not the final decision maker. It's here to augment, not replace, the expertise, the judgment, and the human touch of a doctor.
Which really leaves us with this final, fascinating question. It's not about man versus machine. It's about collaboration. The real challenge is figuring out how doctors can learn to trust their new super consultant. As AI gets better and better at seeing the invisible patterns in our own biology, the question is, will we be wise enough to listen